Swallowing difficulties can affect different people of all ages. The causes can be numerous: stroke, motor neuron disease, multiple sclerosis, learning disability, dementia, Parkinson's disease, head and neck injury, or cancer. Often, swallowing difficulties or dysphagia reduce the ability to take in enough calories, nutrients and fluids to nourish the body, leading to further complications such as malnutrition and dehydration. The one common factor is that dysphagia can become a severe disability and even fatal if it is not managed properly. The fact that the airway and esophagus are connected leads to the risk of food entering the lungs, which can lead to pneumonia and infection. Understanding the normal swallow is one of the keys to beginning to develop a management plan for the patient with dysphagia. The purpose of this part of the DVD is to detail the normal swallow from a clinical point of view. Emphasis will be placed on correlating the normal physiology of swallowing with the relevant anatomy of the head and neck. Swallowing is a complex process and can be divided into 3 phases: oral, which lasts around 1 second, pharyngeal, which also takes about a second, and esophageal, which can take anything between 8 and 20 seconds, with the oral phase under voluntary control and the latter 2 phases under involuntary control. Other factors, including flavor anticipation and visual appeal of the food or drink, can also have an effect on the swallowing process. The oral phase of swallowing can be further subdivided into the oral preparatory and the oral transport phase. In the oral preparatory phase, the tongue moves the food around in the mouth for chewing. Chewing makes the food the right size to swallow and helps mix the food with saliva to soften and moisten it to ease swallowing. The tongue then collects the chewed food or liquid in preparation for swallowing. The second stage begins when the tongue pushes the food or liquid to the back of the mouth. This triggers a swallowing reflex that passes the food through the pharynx to the esophagus. During this stage, the larynx or voice box closes tightly, and breathing stops to prevent the food or liquid from entering the lungs. What actually takes place as the swallowing reflex is initiated is as follows. 1. Velopharyngeal closure to prevent food flowing back into the nose. 2. Closure of the larynx or voice box in a specific sequence to prevent aspiration of food or drink. 3. Contraction of the pharyngeal constrictor muscles in a downward motion. 4. Elevation of the larynx and hyoid bone towards the base of the tongue. 5. Relaxation of the normally contracted cricopharyngeus to allow passage of the food bolus into the esophagus. The duration of this second phase of swallowing is normally around a second in healthy individuals. The third and final stage begins when the food or drink enters the esophagus to be carried down into the stomach. Like the second or pharyngeal phase, the esophageal phase of swallowing is involuntary. However, movement of the food is significantly slower than in the pharynx and usually lasts between 8 and 20 seconds. Dysphagia occurs when there is a problem with any part of the swallowing process. In oral dysphagia, this may be due to weak tongue or cheek muscles, which make it hard to move food around in the mouth for chewing. Food that isn't chewed thoroughly may enter the throat and block the passage of air. An inability to achieve full lip seal can also cause problems. Other problems include not being able to start the swallowing reflex. People with these kinds of problems do not have the involuntary muscular movements that allow food to move from the back of the mouth to the stomach. Another difficulty can occur when weak throat muscles cannot move all the food toward the stomach. Pieces of food can fall or be pulled into the windpipe, which may lead to infection. Dysphagia can affect people in many different ways. For some, the difficulty is in swallowing solids, particularly bread and meat. They may have to swallow several times before the food feels as though it has gone down completely. For others, swallowing liquids may be problematic. People with dysphagia may regurgitate food through the mouth or the nose. Food or liquid can be inhaled or aspirated into the windpipe and lungs. Aspirating food can lead to lung damage, including airway infections and even pneumonia. Depending on the cause of the dysphagia, some people experience chest pain when they eat, which can be due to spasms of the esophagus. It is often described as a squeezing pain under the breastbone. This pain can be similar to coronary artery disease, angina, and the two could be confused. Weight loss, dehydration, and undernourishment are problems that can be experienced by people with dysphagia. Because of this, it is vital to ensure a balanced diet is maintained through careful planning and food preparation with the support of a dietitian. There are many causes of dysphagia. Any condition that weakens or damages the muscles and nerves used for swallowing may cause dysphagia. For example, people with diseases of the nervous system, cerebral palsy or Parkinson's disease often have swallowing difficulties. A stroke or head injury may also affect the coordination of the swallowing muscles or limit sensation in the mouth and throat. People born with abnormalities of the swallowing mechanism may not be able to swallow normally either. Other conditions which can lead to dysphagia include MND, MS, dementia, and myasthenia gravis, a form of muscle weakness. In addition, there are some drugs which can lead to problems with swallowing. For example, phenothiazines, an antipsychotic drug which affect the throat muscles. Dysphagia can usually be classified as one of two types: oropharyngeal dysphagia and esophageal dysphagia. The former is the more common type. Patients with oropharyngeal dysphagia have difficulty in initiating swallowing, but may also have associated coughing, choking, or nasal regurgitation. The patient's speech quality may have a nasal tone. These dysphasias are most often associated with stroke, Parkinson's disease, or other long-term neuromuscular disorders. People with esophageal dysphagia experience the sensation of food sticking in their throat or chest. The patient's description of the perceived location of the obstruction often does not match the actual location, especially if the perceived location is in the cervical area. Motility disorders and mechanical obstructions are common. People with neuromuscular dysphagia experience gradually progressive difficulty in swallowing solid food and liquids. Cold foods often aggravate the problem. They may eventually succeed in ingesting the food by repeated swallowing or by changing their position.